Go ahead.
So, to be quite honest with you, I have no idea what I was thinking when I picked this topic. It's a topic that we face every single day in our practice, but there is such little data out there to say what we should do that some of this is going to be strictly my opinion, and I will tell you when ACOG has an opinion, so you know that that recommendation's out there. Next slide. So, inpatient for delivery. Anybody that is 37 and 07 weeks or greater with preeclampsia with or without severe features should be delivered. There's a couple of randomized trials. Hippocat 1 was one of those trials that showed that conservative management did not lower our risk of a C-section, but conservative management increased our risk of having severe hypertension. The second person that should be inside the hospital is 34 weeks and 07 weeks with preeclampsia with severe features. After this gestational age, it is not recommended to conservatively manage severe preeclamptics. The only exception, I guess, that sometimes the only one I would ever think of would be a cardiac baby that we're trying to get a little bit heavier so that they can undergo surgery. But again, most of the time, regardless of the situation, patients with severe features so who should we put in the house to do inpatient management? The first thing is severe preeclamptics. If you have a severe preeclamptic at 20 weeks, they need to go into the hospital. Even if the baby is not viable, they need to go in the hospital. If you have one at 26 weeks and the baby weighs 350 grams, they still need to go in the hospital. And so once the diagnosis of severe preeclampsia is made, then hospitalization, inpatient management is is the standard. Now, we can do prolonged gestation, try to prolong pregnancy depending on the circumstances, but that is recommended only in the hospital and really with MFM consultation. And obviously, if we have a patient who's unreliable, like uses drugs or something, won't come to her appointment, and she has preeclampsia at less than 34 weeks, I would hospitalize that lady. And anybody with transportation issues, somebody who lives 2 hours from the hospital and they don't have reliable transportation to come in. So there are so those two patients, the prior slide, I think, is basically a hard cutoff. Okay, that those people need to be in the hospital. Next slide. But these are people that sometimes can be managed as an outpatient. So if patients are less than 34 weeks with preeclampsia without severe features, for example, if I got somebody at 33 and 07 weeks, I might manage that patient as an outpatient. But if she's 24 and 07 weeks with diabetes and hypertension, that patient I am going to put in the hospital. So I say that inpatient management considerations should be uh, early onset severe preeclampsia and individuals with increased risk for severe preeclampsia, like underlying diabetes, hypertension, renal, twins, or higher orders of multiples, because they have a little bit more atypical presentation for severe preeclampsia than patients that have these other features. The other thing is, I'm sure you all see this, okay? We have somebody come in at 26 weeks, she's a singleton, she's never had hypertension, and we start medication and send her home. And then the next week, she comes back in and her blood pressure's 150 over 100. We send her to labor and delivery. We start some more medicine. We send her home. Then the next week, she comes back in. She's 150 over 90. And so it turns into a vicious cycle. But if it's early onset severe preeclampsia and they are not responding well to your outpatient treatment or your outpatient follow-up, then it's very important to hospitalize those patients. Next slide. So when you're considering people to watch them on an outpatient, obviously, the criteria are fairly straightforward and are recommended by ACOG. Uh, One is you have to have a reliable patient. Two, you have to assess fetal well-being at least weekly. And um, I basically do antenatal testing on these individuals with a fluid check. Okay. But when you read what ACOG says and in other textbooks, it says that they need at least a fluid check once a week. And we need ultrasound for growth every 3 to 4 weeks. And they should have uh, some baseline labs, a CBC with platelets, a CMP, and a protein creatinine ratio. Now, um, so next slide. So the one of the so for outpatient management, the group of individuals that I think are best for this are your 34-week to 37-week patients with preeclampsia without severe features, the ones that are the same with gestational hypertension, and as I said before, less than 34 and 0.07 weeks in uncomplicated preeclampsia without severe features. Next slide. So this is also outlined pretty much from ACOG. It recommends when we are doing outpatient management, that we see the patient 1 to 2 times a week for a clinic visit, that we do once a week labs. We don't have to repeat the PC ratio once it meets the criteria for preeclampsia. But the platelets and the liver enzymes and the renal function we should observe. Home blood pressure monitoring. Let's skip this and come back to that. But our nurse, as well as us, should give the patient excellent education on signs and symptoms to return, including vaginal bleeding and abdominal pain which are signs and symptoms of an abruption. Um, I just talked with one of my faculty members yesterday, and she said, "Oh, Dr. Johnson, we always talk about right upper quadrant pain, but that help pain, it went all the way to my back and all the way around to the front. It didn't quite hit that right upper quadrant pain." So we have to be very descriptive in how we talk with patients and not just say it's a pain in your right upper quadrant, because often the patient, I mean, like my faculty member actually thought that she'd pulled a muscle. One of my former patients thought she was wearing a new bra and it's the wrong size. Okay, so she had changed her bra several times that weekend and then came in with really high liver enzymes. So just make sure that they know it's not confined totally to the right upper quadrant. And, as far as um, floaters in their eyes. Every time you ask patients, they almost always see floaters. Those are normal. You just have to explain, it's like a firecracker or a light that comes and goes. And then uh, again, I usually do twice a week a NST and a BPP because of the requirement for the fluid check. And the And it is very important to use the right size blood pressure cuff. We can't say that enough, especially with our obese patients. So when we send them home with home blood pressure monitoring, we need to ensure that their machine actually is appropriate size for the patient, and we need to make sure that they understand when to call us, okay? So truly, home blood pressure monitoring, has never been proven scientifically to work, but it's kind of one of those things that I look at and say, well, really, what harm does it do? As long as it doesn't undermeasure blood pressure, and the smaller blood pressure cuffs on a big person tend to overmeasure it. So they tend to come to the hospital more and not less. So as long as that occurs, then I think it's fine to do home blood pressure monitoring. Next slide. So this is the bag of worms. Okay. What are we supposed to do if we have a patient that comes in with hypertension on medication? To me, that one's easy. Okay, because if they come in 155 over 105, it's easy to increase their medicine and then recheck them, because this may just be a increase in chronic hypertension and not really superimposed preeclampsia, but we need to see that patient back, at the end of the week, if you're seeing them at Monday or Tuesday, or at the beginning of the week, or you seeing them at the end of the week. Now, if they are not hypertensive, you got your straightforward G1 P0 healthy, and she comes in at 32 weeks with a blood pressure 160 over 105, then you can start medication, run her labs, check her starting medication. Now, what we have to understand, when we start medication, we're really treating a number, and we're not really improving the outcome of the pregnancy or delaying preeclampsia. So it's important once you start a medicine that you follow up very quickly, and if they fail medication on an outpatient basis, then I would have a low threshold of putting them in the hospital. Again, um, intrapartum is, different. We're to be aggressive. And that compared to antepartum, we're not quite as aggressive. And then my last slide that I want to say is that individuals who come in with hypertensive disorders of pregnancy, after they deliver, okay, we should treat them aggressively. Okay, we no longer are bound by numbers. I mean, it goes down to medicine numbers. And so if a patient is 145/91 in the hospital, guess what? She is only going to get higher when she goes home and she's taking care of the baby and she's sleep deprived and her episiotomy is hurting. So start them on the lower end in the postpartum period than you would on the antepartum period. And so if they are hypertensive and you started some medicine or you're worried about it, then see them within 1 week. And I honest to God think if we were aggressive enough like this, it would decrease our inpatient readmissions to our services because we have seen a lot of this. And then you can also consider sending the patient home with home blood pressure monitoring. Okay?
Thank you very much, Donna, for your presentation. And I'm going to go ahead and turn it over to you as well as the facilitator, as well as Dr. Campbell, to open it up to questions and discussion with our participants.
Thanks.